Welcome to Ostomy and IBD Life. This is a place where we get to discuss all things about having an ostomy, Crohn's, colitis, from the physical to the mental to the emotional issues. I'm Elaine O'Rourke. I've had my ileostomy for 15 years due to Crohn's disease. I work with people who also have ostomies and IBD to really help overcome a lot of the challenges, the fears, the anxieties, the body image issues. So make sure you reach out to me if you still feel like you are just in survival mode. I'm so excited for my guest this evening. Her name is Meghan Markowski. I'll bring her on in a few minutes here. But first of all, if you are tuning in, I love to know where you're tuning in from. We welcome any questions because today's topic is the pelvic floor issues, sexual concerns, bladder, and bowel. So it's going to be really informative and looking at it from the physical therapy perspective. This is a field that I myself didn't even know existed till about 5 or maybe 7 years ago. And I feel like everyone should know about this. It's not just for people who have ostomies or IBD. This is for everyone, as there's so many problems that people have that go undealt with and especially untalked about. So it's great to be able to bring this out, to be able to bring this to light, and to let the general public know that there is help if you are having any issues. If you are on Facebook, I am on Ostomy IBD Life, if you'd like to follow me there. And I actually have a new Instagram page that I just set up. It's called Ostomy IBD Life, just to have some continuity. And of course, on YouTube, you can follow me on Elaine O'Rourke Ostomy, Yoga Ostomy IBD. If you have an ostomy and you would like to get my free download, just go to my website, which is elaineo'rourke.com. And I have a free download, which is 3 ways to eliminate fears around your ostomy. And if you have IBD, you can go and grab your free download, 5 mistakes even well-informed people with IBD make. Meghan Markowski, let's bring her on and I will introduce her. Hi, Meghan.
Hi, Elaine.
Thank you so much for joining me today.
Absolutely, my pleasure. Thanks again for having me.
Oh, my pleasure. So Meghan is a clinical specialist in pelvic floor physical therapy at the Brigham Women's Hospital in Boston, Massachusetts. She also gives lectures and continuing ed talks at the Harvard Medical School, and also for people within the medical community, because even within the medical community, this is a fairly new topic, even though it's been around for years, but it's only come to light, and also helps to educate the general public. So I know that just from our conversation last week, I've already learned so much, and there's just such amazing information and help that people can get out there. So first of all, Meghan, can you explain what the pelvic floor is?
Absolutely. So to start with the pelvic floor, typically what we're referring to is all of the musculature, as well as some of the structures within the bony pelvis, the different organs, the bladder, the bowel. But mostly when we talk about pelvic floor, we're talking about the musculature of the pelvic floor that kind of runs from the pubic bone all the way back to the tailbone, and everything in between in the middle here. So everything's sitting here at the base of the bony pelvis. And all humans have one, males and females, believe it or not, and they're remarkably similar. This is the female here, but I'll show you the male pelvic floor here on the right. They're very similar looking. They're just a little bit more narrow in our male counterparts than the female. But what we're talking about are these muscles of support that form like a bowl or hammock, if you will, at the base of the bony pelvis that do all kinds of functions, from supporting our bladder, bowel, sexual function, postural support, internal organ support, and again, of course, as well as sexual function. So these muscles do a lot of things. And again, as long as we're human, we have them, males and females and people of all genders. And so, unfortunately, with any muscle that we have in our body, things can go awry, just like we see in the rest of the body. And even though these muscles are more hidden, if you will, and more private, they are skeletal muscles and voluntary muscles, just like the rest of our, if we think about biceps and things like that, they're voluntary muscles just like that. And again, things can happen throughout a person's lifespan or with certain diseases like inflammatory bowel disease of any kind, or, pregnancy, deliveries, aging, young, poor bladder habits, poor bowel habits, really benign things can cause dysfunction in this area.
Okay, right. So then what then is the role of the pelvic floor? Because it seems like it does a lot.
It does do a
In
lot.
what you just said there.
Yeah, absolutely. And so again, if we kind of look at these muscles, and you can see they form this like bowl or hammock, if you will. So if my fist represents all of the internal organs, our internal organs sit on top of these muscles, as does the rest of our torso. So again, everything from postural support, keeping our internal organs in place, closing off the urethra and the anus to preserve bowel and bladder continence, as well as opening the urethra and the anus to allow urination, defecation, gas passing, or in the female, opening the vagina to allow penetration of anything or birth of a baby. And the anus, same thing, opening, whether it's for sexual purposes or examination purposes. So again, from bladder function, bowel function, sexual function, postural support, and internal organ support. These muscles do a lot of things.
Yeah, they do. And actually just, I'm a yoga teacher as well. And I know I'm always, can feel like even with the breath, we talk about we have the breathing diaphragm, but also, what we refer to like the pelvic floor diaphragm, because when you just inhale, you can feel that pressure down into the base of the pelvic floor. And then as you exhale, you can feel that kind of like lifting up. So, it's amazing.
Precisely. And that's just it. These muscles work along with our breathing diaphragm. And they're the floor of the core, if you will. So these muscles sit at the base where our abdominal muscles, which when everyone thinks of core, they think of abdominal muscles, but it's some of the abdominal muscles, the breathing diaphragm on top, the pelvic diaphragm or pelvic floor muscles below, and some of our back muscles on the back end of things. And that really is what comprises the core. So certainly with yoga, tuning into that breath and feeling those muscles engage is a wonderful way to find them. Of course, unfortunately, for a lot of people who have dysfunction, that kind of normal descent with inhale and rise up with exhalation doesn't always happen. But ideally it does, and it's a great way to identify with those muscles.
Right, right. So then what exactly, so you're a physical therapist. So what exactly is physical therapy for the pelvic floor? And I'm sure there's tons of people out there that had no idea that, wow, you get physical therapy, you get a shoulder issue, you get a knee issue, and, you're given different exercises to do. But what is physical therapy for the pelvic floor?
No, excellent question. And obviously one I get asked all the time. So I think going back historically, this became a more focused area of practice, believe it or not, back in the 1970s. And so, even prior to that, it was back in 1948 that Dr. Arnold Kegel discovered, like, hey, these are voluntary skeletal muscles, just like the rest of our muscles that we think of in orthopedics. And they have function, particularly for sexual function and bladder and bowel function. And so we can strength train them. And if we do, we can improve things like sexual functioning or bladder control, etc. And so, again, going back to the fact that these muscles are skeletal muscles, just like your shoulder and everything else, physical therapists are the experts in the musculoskeletal system. And so it falls in nicely with what we do as physical therapists. But the training involved to really address these muscles, which involves internal examination and treatment, really is a special skill set that beyond our entry-level doctoral degrees, you would go on for additional training to really learn and become skilled in. But even though it's, again, an intimate and unique niche within physical therapy, the guiding principles are really very similar to what we would do in orthopedics, believe it or not.
Wow. And so can I ask you, what even got you involved with, because it's such an intimate topic. You're dealing with, the most intimate parts of people. So what got you interested even in delving into this and specializing in this area?
Yeah, absolutely. Great question. And so, really, I would say it goes way back. I knew at a very young age I wanted to be a physical therapist. And part of the reason was I thought how great that what we do with our hands and our brains make people better. And I liked better than being a physician. I liked the time I got to have with my patients versus, just we get to develop more relationship and time with our patients as physical therapists. And I thought that was really great. And as a very young child, I always was kind of a little raging feminist. And when I first had heard about pelvic floor physical therapy back in the 90s, it was more, women's health. And certainly we've come a long way since then. And, all of us in any gender has a pelvic floor. But I think going back to being more like a raging little feminist, what always struck me about being a woman, even if you don't have anything major wrong, I think everyone's had that experience of kind of being dismissed, like it's a pelvic floor issue, or you're a woman, it must be something to do with your period, and it just never kind of sat well with me. And so it was in graduate school that I saw an article about niche practices in physical therapy, and one of which was pelvic health, and it kind of struck me like, oh, again, what I think is so great about being a PT is, what we do with our hands and our brains makes people better and improves their quality of life. But how great is it to be able to have a practice that really focuses in on these issues that are typically otherwise dismissed, or women are made to feel like, well, maybe just have a glass of wine before sex and everything will be okay, instead of really getting to the root cause of these problems. So it kind of appealed to both my physical therapist self, but also my feminist self of like, wow, we can use our skills in this unique setting to really enhance people's quality of life. And especially when we talk about pelvic floor disorders, people who can't consummate their marriage because it's so painful to have sex, or someone who is having bowel leakage, who is otherwise fit and healthy and young, but is so ashamed of that. They don't want to leave their house. They don't want to go out with their friends. They don't want to do the things that, they should be able to do, what they want to do because of these more intimate or private issues. But again, the skill set we have as physical therapists can help them with that. And what a great quality of life improvement for those people. So selfishly, it's a very rewarding career.
Yeah, and like, thank you for going into this field. And it is such a shame that up until more recent times, even though the physical therapy for the pelvic floor has been around for a while, I think so many people haven't been educated that this is something that they can get help in. And even I'm sure you find within the medical field also for your doctors to say, listen, this is what you should go and do. And I even just know from myself, from having Crohn's for all of those years, because you're always clenching your bum because you're always like running to the loo, it's hard to keep things in, that I even now to today, I still clench my bum. It's just so ingrained in me. It's my constant mantra: relax your butt cheeks, relax your butt cheeks. So we all develop these different habits, and that could then be having other ramifications within the whole pelvic floor area.
Absolutely.
Yeah. So let's get right into the juicy stuff. First of all, can you explain to us, what sort of sexual dysfunction can PT for the pelvic floor help with? And maybe we'll start off with the female anatomy.
Mm-hmm. Sure. So, but quite honestly, to even address all genders, because it's, believe it or not, very overlapping.
Okay.
Primarily the things that we address with sexual dysfunction are pain. Now, whether that's pain with penetration, whether it's vaginal penetration or anal penetration, pain with orgasm in either, in any gender, pain with erections, pain with ejaculation. So pain is probably the biggest issue that we address in, again, any genders when it comes to sex. Now, certainly some of the other pain issues that maybe someone doesn't have pain with sex per se, but they have, chronic abdominal pelvic pain because of fistulizing disease or whatnot. and just the ramifications that can have on just muscle tension in this area, not feeling desirable, having, a low libido as they don't feel good. So of course they're going to have a low libido.
Right.
And so even indirectly, if it's not specific, sex related pain, but we know that the impacts of those other types of pains or dysfunctions will impact their sexual beings. If we address their pain or their incontinence, because sometimes it's a fear of being incontinent or something like that during intimacy that can lend people to get different muscle dysfunctions, whether we're directly treating the problem of pain with sex or something related to it, those are all things that we can address. Sometimes too, because muscle control is involved with orgasm, sometimes orgasm function can be improved. Obviously, orgasm is a very multifaceted entity that can have neurological inputs, vascular inputs, brain inputs, as well as muscular inputs that we can't always promise that, orgasm will absolutely be improved, but sometimes because of all the other work that we're doing, it can be.
Right. So then in regards to bladder issues, then what would be the role of PT?
Yeah. And so with the bladder, we're dealing again with the same muscles of the pelvic floor. And so when we think about muscles of the pelvic floor, usually they fall into one of two categories. They're either overactive, can't let go, oftentimes, but not always associated with pain, or they're underactive, weak, not supportive, likely causing things like urinary incontinence, fecal incontinence, pelvic organ prolapse, things like that. Again, it's not always that way, but that's generally what we're looking at. So with a bladder problem, whether it's an issue of like incontinence or maybe urinary urgency frequency, we could see muscle dysfunction either as underactive or overactive. But anytime we're dealing with the bladder itself, not the muscles of the pelvic floor, but the bladder itself is a storage organ that we are all as humans trained by habit. And we think about that as when we're children, none of us are born continent. We have to be potty trained at some point. And because bladder training is habit training, and usually we learn that when we're quite young, but things can happen over time that changes our habits. And all of a sudden, what we had learned as a child now is not good. And we start to lose that ability to be content. And so we have to retrain not just the pelvic floor muscles to support the bladder, but to teach that bladder how to store urine or how to effectively eliminate urine. So a lot of what we're dealing with the bladder is also habit training. So not just muscle training. So a lot of patient education. What should you be drinking? What shouldn't you be drinking? When should you urinate versus when should you defer? And things like that.
Oh, that's really interesting. Yeah, I hadn't even thought about that retraining. And as you were speaking there, I was just thinking, again, from the yoga perspective, and I work a lot with the body and observing the body. It's exactly the same thing. Most of us are like, overworking one muscle and the other muscle's getting lazy. The other muscle's gone off for lunch, and isn't participating as much. So it's kind of like this, pretty much like the same thing, right?
Exactly. And that's where, as intimate as we think of these muscles and obscure, it really all comes back to orthopedics. Again, these are skeletal muscles. We can learn to activate them correctly or not so great, but they can always be retrained, whether that's to strength train or up train them or to teach them how to relax or down train them.
Right.
And oftentimes doing both.
Right. And then I would imagine then it would be much the same then with bowel issues. Like what, could you just talk a little bit about that?
Absolutely. And so similarly to the bladder again is a muscle. It is not a voluntary muscle. It's a smooth muscle. So not under our conscious control, but there's habits we can do to retrain the bladder. With the rectum or the bowel, that's also a smooth muscle, not under our voluntary control. So the pelvic floor muscles beneath help to support that bowel by closing off the anus or opening the anus. So again, part of it is muscle function. Do we need those muscles to open better? Do we need those muscles to close better? But then what impact does that have on the bowel or the rectum itself? And so certain activities of the muscles can impact what the bowel is doing. So again, habit retraining too, there's right and a wrong way to be sitting on the toilet defecating. How are you pushing? And avoiding of straining, and certain ways that we can position our body to make it easier to defecate or more complete. And then also a big patient education piece that's unique to the bowel would be, what does your stool consistency look like? And so is it water? Is it mush? Is it formed? Is it rock hard? And so what the stool consistency looks like is going to really dictate how well people evacuate, whether they feel complete, whether they feel a sense of needing to strain or incompletion, or if there's fecal leakage. So again, some of it is motor control, but a lot of it is also the stool consistency and what people's behaviors or habits are surrounding toileting.
Oh, wow. So then I'm sure we're all wondering this. How do you actually evaluate this? How do you evaluate for like sexual dysfunction? How do you evaluate for like bladder, the bowel? Like, what do you actually do when someone comes in and presents their case to you? And before you answer that, if you will, I'll check in on the comments here in a few minutes, but please post up any questions, because I'm sure, like me, you're hopefully learning a lot of stuff. So if you have questions or need clarification, just post them up. Let me know where you're tuning in from. Say hi, give me a wave, give a like, and all of that good stuff. Okay, so I walk into your office. Got all these issues. What happens? How do you evaluate?
Yeah, so the first thing we start with is just a really thorough history intake. So I usually start with, tell me what brings you in. And then, whatever the situation is that is your main complaint, if you will, or issue that you're having, I'll ask a lot more specific questions. And regardless of what someone's coming in for, like let's say it's pain with intercourse, I'm still going to always ask questions of very specific details about bladder functioning. How often do you urinate? Do you leak urine at all? Do you feel complete after you urinate? Do you have to wake up at night to urinate? Do you ever have such intense urgency you fear you can't get to the toilet in time? And then similarly with the bowels, how often do you defecate? What does the stool look like? Do you strain? Do you feel a sense of incompletion? Is there any sense of is there any fecal leakage at all? Do you need to use manual techniques to help get the feces out? And then from a sexual function, is there issues with sex, whether that's sex with yourself, masturbation, orgasm, penetration of any kind, even if you're not having, penetrative intercourse, but does arousal hurt? Does using a tampon not feel good? Have gynecological exams always been painful? Or, in a male, is anal penetration painful when you go to the doctor and they do an exam? Anything at all, difficulty with erection, ejaculation, is that difficulty pain, etc. And so regardless of what someone's coming in for, we're going to thoroughly ask all of these other questions to kind of paint the picture of what is the function of the pelvic floor muscles, what is the functionality of their sexual bodies, of their bladder, of their bowels, and kind of really pulling together a picture before we even touch the patient. And so then before we touch the patient, I'm going to give a very thorough explanation of, who I am, what I do, how would we go about doing this examination. And so primarily though, in order to assess the muscles of the pelvic floor, we do have to do an exam of some sort. And typically that exam involves two pieces. The first thing we would do is look externally around the pelvis, looking specifically at the skin. And so is there anything outlying about the skin, particularly with IBD? Is there perianal disease? Is there active, wounds? Or is there any kind of perhaps underlying skin issue, whether it's like a yeast infection or anything such as like in a female de-estrogenization? Are they postmenopausal? Are they breastfeeding? Are their estrogen levels low? But then we'll get a very rudimentary sense of their muscle function just by looking at their perineum, looking at, this part of their body around the anus, between either the vagina and the anus or the penis and the anus. And we'll have them do things like cough, bear down, try to tighten the muscles as if they were stopping gas. And I'm just looking to see, how do their muscles respond? And we can do some external palpation too around just like the opening of the anus and the vagina, and same thing in the male, penis and anus, to see, is there pain, are there muscle spasms, scar tissue, anything at all that, again, as physical therapists, we could address. And then eventually, to get the truest assessment of pelvic floor muscle function, we would do an internal vaginal or rectal exam based upon who's in front of us, what organs they may or may not have, as well as what their predominant symptom is. But in order to really assess these muscles, the internal exam, which is just a gloved and lubricated finger, would best allow us to assess not just the muscle function of how well can it contract and relax, but what happens, when we palpate certain muscles. Does that provoke pain? Does that pain seem similar to what they would experience if they are having pain? Or at the end of the day, are these muscles overactive, underactive, somewhere in between?
Well, so I would imagine that, wow, I can't even imagine what the training would be like, because, with regular physical therapy, you can see, when someone's gait, how they're walking, or you see how they're using their limbs, or, you can see a bit more accurately what is going on. So can I ask you, in your training, how do you really train for this?
Mm-hmm. Excellent question. So, 20 years or so ago, when I was training, the protocol, which some of the schools still utilize, it would be all physical therapists. There'd be about 30 to 40 people in the class. And what would happen is you would have you'd learn all these different things. And over the course of 3 days, these intensive training seminars, when you broke out into labs, you would be the patient, I would be the therapist, and then we'd switch. And
right.
You're learning one-on-one with each other. And, some people in the class may have dysfunction, some people in the class may not. And certainly, anecdotally, we think that's probably one reason why there's so few of us who do this, because sometimes it's very intimidating for people to even want to pursue because of those reasons. But at the end of the day, in my opinion, I think it's a wonderful way that even if you don't have dysfunction, to really eventually empathize with your patients, because when people are learning, you learn pretty quickly what a bad exam feels like.
Right.
You never ever want to recreate that with anyone coming to your office. But again, without being crude, pelvic floor muscles, vaginas, perineums, penises, they're like faces. We all have the same parts, but they're shaped a little bit differently. They're placed a little bit differently. And sometimes, with life and surgeries and, inflammatory conditions, things change and they look a little bit different. So to be able, in the course of a 3-day weekend, repeatedly over years, because there's multiple levels of training that you go through, you're seeing at least 30 other people and all these different presentations. So come Monday morning, you go back to your clinic and you have a patient you've already examined a very good amount of people, to kind of get an appreciation for how different this is and be able to visualize what you can externally, but almost, training your exam finger, if you will, to be able to feel the things you can't see, to be able to get just as much of an appreciation for what the muscle function or dysfunction is as we would if we were watching someone walk down the hall, like we do in PT school.
Right. Thank you for sharing that. I just want to go in and see if there are any comments yet, or any questions from anyone. I see some people saying hi here. Hi, Justin. You're always great for tuning in every week and helping to share the information. I'm not sure if that's a question from Noberto, degenerative disc disease. If you have a specific question, or maybe that's what you have, that probably is. Okay, thanks. So post up your questions. Sometimes there's a delay with getting the questions, depending whether you're watching on YouTube or on Facebook. But know that I always do go in and check them afterwards. So if you're watching this on the replay and you got questions, you can still post them up and I will try and get some answers for you. Okay, so let's continue back in our discussion. So yeah, feel free to post up or put in where you're tuning in from. That's always fun for me to know. What was I going to ask next? Oh, yeah. So then in regards to specifically people with say like with IBD, let's say that. And so what sort of problems do you come across? Is there any theme or, I know that some people experience anal prolapse, and then you have for women, the vaginal rectal fistulas. So can you talk to us a little bit about maybe some of those things and other issues that people present with?
Absolutely. And so some unique things with people who have IBD, typically like a very classic pattern, if you will, is kind of what you were describing even with yourself. When you have IBD and there's this constant urgency, frequency, particularly of loose stools, you never know where the bathroom is, and those muscles very quickly learn how to clench. And because again, inherently these muscles are postural, they pick up on that habit and that becomes your new posture. And when we have tension in the pelvic floor muscles, and we kind of look at the anatomy again, so when these muscles contract, they're going to close off the urethra, the vagina, and the anus, or the urethra and the anus in males. And so when there's tension there, that can make elimination more difficult. So when you do finally go to the bathroom to urinate, to defecate, to pass gas, or you want to relax your muscles to allow penetration to happen, whether sexual or not, those muscles are likely not going to be able to let go. And therefore, it's going to inhibit your ability to have pain-free penetration, to potentially evacuate your bowel and bladder fully, which could then lead to symptoms like constipation, and fecal incontinence, urinary urgency frequency, incomplete urinary emptying. And so it's very common that even if someone, again, like presents to the clinic with, oh, I'm really having a lot of pain with penetration, when we ask further questions, because these muscles have shared functions with all of these different orifices, we often see overlapping conditions. So somebody who's really clenching tight because of urgency frequency of defecation likely also has urgency frequency of their bladder and potentially pain with penetration or just pelvic pain in general. So that's a very common presentation. But then again, going back to specific IBD related issues, if there is fistulizing disease, and now we have a lot of, perianal skin pain and issues, abscesses, breakdowns, again, all those things can cause pain. And whether it's the skin or the wound, that's really the painful entity. Because these muscles are in close proximity to that, when we're in pain, our body clenches or contracts to kind of protect us, if you will. But unfortunately, the longer it stays in that clenched position, even if we heal the skin and disease is in remission, it's not like the muscles get that memo. So those muscles can still be propagating a certain amount of pain, and it's not addressed until we go in and actually focus on the muscle that's just not letting go.
Right. And so then people with an ostomy. So some people with ostomies still do have their rectum and anus there. Some of us have it removed. But I would presume that you can still have PT done. Like, it doesn't make any difference because you have an ostomy. Would I be correct in saying that?
You are absolutely correct. And you bring up a great point, because certainly, like you mentioned, some of my patients with ostomies still have their anus, they still have their vagina. But plenty of people I've seen no longer have an anus, or they've had to have a vaginectomy because of cancer or other kind of radical surgeries, whether it's disease progression from IBD or some other issue such as cancer. And so for the most part, except in some very extreme cases, the pelvic floor muscles are still there. And so that can be helpful or not helpful, depending on if those muscles are also causing dysfunction. And so plenty of cases we can't do an internal exam, but there's often still work that we can do externally to assess the muscle function and to, again, work with whatever scar tissue or fibrosis could be there to improve someone's function, assuming that they're having some kind of dysfunction.
Right. And then would you say, because I have an ileostomy, so the rectum has been removed, so like everything feels different. Even when I go to see my GYN, like the cervix is in a different position. Everything feels differently because you don't have the rectum there for that little extra padding. So do you see a lot of dysfunction then when people have that removed?
So not necessarily, to be honest, and whether that's a manifestation of, usually I see people at particular points in their life, versus like seeing someone over the course of like their disease progression for 10 years or what have you. But in the experience I've had in the last 20 years, usually, just having a particular anatomy part removed isn't usually the dysfunction. And because that particular anatomical part has been removed, it's usually a positive thing because having had that particular organ there was causing more dysfunction. And maybe I wasn't there with them prior to when that was actively causing dysfunction. I do have, a couple patients that I'm working with right now who are very much in the midst of, maybe they're switching from their ostomy and might have more complex surgeries. And so it'll be interesting to kind of answer that question with some particular patients that I'm working with right now. But it really kind of depends on every individual's specific presentation. And so certainly sometimes having loss of anatomy can present in certain dysfunctions. But I would say, again, in my experience with IBD, when we've had those particular parts removed, usually the dysfunction that I'm seeing them for is unrelated to that per se, because the fact that that piece has been removed has really enhanced their overall function in other ways.
That makes a lot of sense, actually. Yeah. So then when someone comes to you and you do the evaluation, you take their history and everything, then what is their homework? Because with regular PT, you're given a bunch of exercises. So what does that look like with the pelvic floor? What are some of the things that you would have someone do?
Yeah. And so again, probably the thing that we're dealing with the most, generally speaking, is actually teaching these muscles how to let go, believe it or not. Because certainly when people, generically think about, the pelvic floor or, they always think Kegels, strength training, contraction, contraction, contraction. And certainly sometimes that is the case. But more often than not, if strength training is even something that someone needs to do, many times they're so tense, we need to teach those muscles how to let go. And that's probably the hardest homework we'll teach anybody how to do. And so really the term that we use in those cases to teach someone how to let go is something called biofeedback. And biofeedback has a lot of different meanings to a lot of different people, but by definition, it's teaching someone to get voluntary control over their bodily responses that they typically did not know they had voluntary control over. So when we think about these muscles and they have this ability to tighten and lift and to move down and open, but they're doing it on such a minor scale. We're talking maybe a couple of millimeters of squeeze and lift and release. It's not huge. Mm-hmm. And like you were saying earlier, in typical PT, you can see someone doing it, or you could, watch your own arm moving. It's kind of hard to do that with the pelvic floor. Certainly we do use mirrors and we use our exam finger as like a tactile cue for people to feel around, but sometimes that's not enough. And so there's other types of biofeedback or tools that we can use to give people awareness to this area to really try to find these muscles and get these muscles to move as they should. So that's kind of our training and skill as pelvic floor physical therapists, is to try to figure out how can we get these people to feel what their muscles are doing. And then if they can feel what their muscles are doing, how can we then teach them to do the desired response that maybe they're not doing? And then that becomes their homework. So an example, when someone's really initially having a hard time finding their muscles or feeling whatever excursion is there, diaphragmatic breathing, or like you were saying with yoga, taking that nice deep inhale, feeling the pelvic floor muscles drop, and then exhaling, having them come up, and passively, they're not making that happen, they're just observing it, can be like an initial homework. But then our goal is to not necessarily have to rely on the breath per se, but can we get them that voluntary control back by, engaging their abdominals or perhaps their breath in a different way, or really finding these muscles and making them work under their voluntary control. And so every time we meet with them, finding a little bit more fine tune of how to do that. And sometimes, when they go home, their homework is to look at their perineum with a mirror and see this little bit of muscle excursion. And maybe that's something we've done in the clinic. Or again, if we're using sensors or tools, if you will, like a biofeedback electromyography or probe, some people will call it. There's these little, devices that people can purchase that they can kind of feel the muscle move around. So there's lots of different ways to get people to find those muscles and then teach them throughout the day to let go of the tension or contract, depending again on what the specific dysfunction is. But it's so much about how much these people are doing at home, because when they're in the clinic, I can get their pelvic floor muscles to do all kinds of great things. But that doesn't matter. They're with me for 30 minutes once a week. They have to go home and use this muscle repeatedly every single day. And that's what's going to retrain that muscle to be under their control and do the right things at the right time.
So, and I would assume that it would be a bit like regular PT, that obviously everyone coming in the door is different. So the length of time and the exercises are going to be different. But, when you see people, about how long would it take? Of course, this is a hard question to answer, but, how long do you typically see someone for or follow someone for?
Yeah. Excellent question. And so certainly that's like the $1 million question that everyone wants the answer to. If I can backtrack a little bit, the other big part of homework, though, for our patients is really that patient education. And so if they're doing something that's painful, we don't want them to do it. If they're, drinking nothing but Diet Coke all day and they're having urinary urgency frequency and a lot of gas, they need to not do that anymore. So a lot of like that patient education and behavior retraining is another big, big component of their PT homework, in addition to the muscle control. But that being said, getting back to this question, it's how long does it really take to get muscles to do what we want them to do? And whether it's, again, strength training or down training, teaching them how to relax, it is very individual. I would say generically, it usually takes on average a good 6 weeks or so, 4 to 8, we'll say, weeks, to really get people to have control of their muscles. Now, don't get me wrong. Sometimes I can get that to happen in the first time I meet someone. Sometimes it can take a really long time. And certainly everyone comes with their own unique awareness of their body. And so some people really have a hard time tuning into their body. They really can't feel what their body's doing. And other people who, have an amazing awareness of their bodies. And because they're coming in with that awareness, it's very easy for me to come in and say, okay, so you feel the muscle doing X, we need it to do Y. And let me have you do this, this, and this. And all of a sudden Y happens. Great, go home and practice that. So those people will probably be on the shorter end of that. But I would say on average, like you're usually looking at like a good six-ish weeks or so to really establish muscle control. And then we want to see, with that muscle control, how do your symptoms improve? So on average, we're probably seeing our patients 8 to 12 visits. And typically we see people once a week or so. So, giving a really gross ballpark, maybe 3 months, if you will. Right. But we would expect to see like tangible progress within that first like 4 to 6 weeks. And then, ideally reaching to their goals beyond that.
Now, typically, so if people are watching this and they're like, oh my God, I need to go and see a pelvic floor therapist, how would someone typically go about that within the States? Because that's where you're based.
Right.
How, like, is that done through you have to go through your regular primary care physician, or would it be through a specialist? So how would someone get hooked up with someone like you?
Excellent question, and quite loaded question. And so depending on where in the United States, most states now have what's called direct access to physical therapy. So in many states, theoretically, you as the patient could just, walk in off the street, no referral whatsoever, and be evaluated by a physical therapist. legally. Now, the problem becomes in who's paying for that. And so many insurance companies, which is very provider dependent, so whatever insurance program you have and specific plan you have, often is the dictator of how do you get to see someone like me. And so sometimes the referral or prescription, if you will, for physical therapy comes from the primary care. Sometimes it comes from, maybe their Crohn's and colitis, gastroenterologist. It could come from a variety of sources, or even the patient themselves, depending on really who's paying the bill, what insurance company they have, and what are the rules and regulations in their state dictated by their insurance company, unfortunately.
Right. And so, and just as a reminder for people that are watching, so if this is of interest to you, you'd be looking for a pelvic floor physical therapist. So it's a complete specialty within the physio realm. So let's just pop out into the comments and see if there is any other questions. Oh, now we got a bunch more. Okay, so Anna, and I'll bring this in here so you can see it as well. So Anna has perianal disease. Ever since I had a seton put in, I felt my orgasms become weaker. Not sure what to do to strengthen them. The seton is out and now getting a stoma, so might be good to look into when the area relaxes a bit. What do you think about that?
Well, I think that's a great question and very well thought out. She's very much thinking like a physical therapist. I'm quite impressed. And so specifically with perianal disease and setons, there's a lot of things going on. Having a seton in place is not a contraindication to having physical therapy. So in a case like that where orgasms are diminished, so the good thing is you're still having an orgasm. So there's still some component of pleasure, but it's definitely diminished. And of course, there's a plethora of different things that could correlate with. But if we think about it purely as musculoskeletal, if there is a musculoskeletal component to it, she kind of hit the nail on the head. It could be that her muscles are weaker, but then if that's the case, why are her muscles weaker? Are they weaker because they've just gotten debilitated over time from not engaging them? Or are they appearing weaker because now there's tension there? Having a seton put in, having that drainage, having it placed in, taken out, placed in, taken out, not knowing exactly what's going on in her particular case, it would be very much worth her while to have a professional to assess her musculature to see what are her muscles doing. Are they contracting too much? Are they relaxed too much? Is there something in the middle where they need to learn how to relax better and then be strength trained? Are there maybe some muscle spasms that could be inhibiting the muscle function? But of course, certainly there's lots of other factors that could be feeding into a diminished orgasm. Is there discomfort now where there wasn't before with penetration? Is there, maybe some issues with just feeling attractive because, there's appliance there now, maybe there wasn't before? Or is this someone who's maybe had a seton on and off again for a long time, and that's not an issue? So that's where, really kind of picking it apart and trying to figure out, well, what's really the issue here? But, I'm impressed that she kind of thought on both sides of the equation of her muscle function. It could be muscles that are overactive, it could be underactive, or it could be a little bit of both.
Right. Thank you for answering that. Hopefully that was helpful, Anna. Then Lenora is wondering, is there any exercises that you can do at home?
Yeah, so everything that we would teach someone is eventually something that they would do at home. Absolutely, the tangibility of everything we do has to be able to be done at home, because again, you're with these muscles 24/7, and the little bit of time, in the clinic every so often isn't going to be enough to really change what we need the change in those muscles to be. And so the problem is generically giving out exercises isn't really helpful. And we have plenty of randomized controlled trials that really show that. And so as much as I would love to say, oh yes, anybody with IBD needs to do X, Y, and Z exercise, there's no way to really say that and actually help people. But if there is,
sometimes it could be that it needs strengthening, or sometimes it needs the relaxation to come in there. So you're not going to know until you actually have that evaluation. So Lenora, I would definitely suggest going and seeking out a qualified person to find out what you actually can do.
Right, because if there is something like, let's say, someone thinks they need to be strength trained, but really their muscles are tense and overactive, they could actually cause more dysfunction. And likewise, if someone's, really underactive and they're trying to do things to relax, that could also cause some additional dysfunction. So we don't want people necessarily taking it into their own hands, but not everything is going to be this 3-month ordeal or more with a physical therapist. Sometimes just getting an assessment, kind of seeing where their muscles are, what their goals are. And sometimes things are really straightforward and proceed pretty quickly.
All right, thanks. Now, Sandra has a comment question here. Sandra had radiation treatments fused my vagina closed. Surgeon cut open, but traditional intercourse is too painful to participate. Disappointed and having a difficult time accepting. Yeah, that's really hard, Sandra. Do you have any suggestions for that, or any thoughts on that? And I've never even heard of that before. So is that something that is, somewhat common? Meghan?
With radiation, certainly we see a lot of different damages. And so unfortunately, having some kind of an occlusion partially or fully of the vagina because of something like radiation or other disease processes can happen, and certainly a fair amount of the things I see in my practice. Depending upon, again, the severity of it, sounds like she might have had a surgical procedure to perhaps open things. And if that's the case, there's a lot of rehab that can be done to at least see, can we optimize her function? Can we have some penetration? So depending on, again, the quality of the tissues and exactly what surgical procedure was done, and her motivation and her surgeon's okay, that is someone who potentially could have some capability of penetration restored. That said, worst case scenario, let's say all the good intervention doesn't pan out, but working with a physical therapist to try to discover other ways to have penetration or intercourse in a way that would be conducive to whatever feels good for her and is okay with her partner. And so sometimes just brainstorming different ideas. There's different types of devices out there. For example, if someone can have a little bit of penetration but not full penetration, like we see this a lot in people who have had pelvic cancer surgery and they've had to have like a partial vaginectomy. They might have maybe like an inch or two of the vagina remaining, but not the full depth of the vaginal vault. And so there's like some devices out there. One that was promoted a couple years ago is something called the ONUT, OHNUT. And that kind of is a device that their partner, assuming the partner has a penis, would put on their penis to kind of like give the sense that the vagina is longer than it is. So perhaps some penetration can happen in the vagina, but some for the partner would be external with these devices that can kind of mimic the sensation of vaginal penetration. But obviously it depends on, what is your goal for sex? Is it penetration? There's lots to be said for outer course and ways to be sexually intimate with someone without having vaginal penetration or anal penetration. There's lots of different ways to be sexually intimate. And sometimes these things are beyond the skill set of a pelvic floor physical therapist. And there's a whole branch of therapy called sex therapy, where there's sex educators, counselors, and therapists out there who really help the person and the couple, if they're in a coupled relationship, where they can really try to figure things out together, and partly being an acceptance of perhaps there's going to be a new norm, to try to work through together to find something that really is satisfying for the person and or the couple. So there's lots of different avenues that could be approached, but certainly, starting with rehab would be a great way to just see, is there anything that could be done? Because I could see a lot of different things that could potentially help that person.
Yeah, great, Sandra. So you can listen to that back on the replay as well, because that was a lot of great advice and insight there. And I would say, it is really hard, accepting these things. And this is a lot of the mental and emotional issues that go along with having cancer, having IBD, having an ostomy, having any disease. And that's where I work with clients as well is more like that mental, emotional stuff, because that is huge. And sometimes that just getting through the emotional stuff, that can be such a huge barrier as well, and being able to clear that energy up as well. So Sandra, you can keep us posted. You can keep me posted if if you take any of this to advice and get any help, and let me know what happens. Okay, let's see what other questions we have. So Anita, hi Anita. What about let me bring this question in so that everyone can see it. What about the Attain device by In Control, or the one with the butterflies? Are you familiar with that?
I'm familiar with some of the In Control devices. So there are all kinds of devices out there. Again, some of them fall under the line of that biofeedback that we were talking about before, like surface electromyography, or ways to depict what's happening in the muscles with certain devices, or even electrical stimulation. So there is some limited role for that. In physical therapy and any branches of medicine, as any of you may be aware of, everything nowadays is evidence-based. And so we're always looking at randomized controlled trials to see what can we be doing better, what best serves our patients. And when we look at some of the devices like that, whether they're specific like biofeedback devices that go inside the vagina or the anus, or even electrical stimulation, there's a limited role for them. But oftentimes those devices and the electrical stimulation does not pan out in the research. So they can be good for very particular populations, but it's not always as revolutionary as we would have liked to have thought, especially when we look at the research. But they are options out there, and they certainly can be appropriate for the right, properly selected patient population.
Great. And Anita also says, I just see another comment that, yeah, not all PTs are specialized in PFE, which I presume is pelvic floor.
Exactly. You have to have someone who's specially trained in pelvic floor physical therapy.
Absolutely. Yes. This isn't just your regular physical therapy at all. So thanks for re-emphasizing that, Anita. Karen says, great acknowledgement about the awareness of the body, which is so important. And yes, it is. So Anna says back, thank you. Oh, you're welcome, Anna. And Anita, actually, we should have, this is a good point for those that aren't familiar with what aceton is. Could you explain what aceton is?
Aceton is essentially a small little tube that promotes drainage, particularly when there's fistulizing disease, and it kind of comes out perianally, or wherever, again, the specific drainage needs to occur. And so it's just another device, if you will. Usually I've seen them in my patients, usually temporarily, but sometimes people will have them on and off over the years, or over a certain period of time to promote drainage. So it's usually like a little tiny tube, plastic, that comes out perianally.
Yes, I even believe that I had them at one stage, extremely uncomfortable. And yeah, that definitely, with all the drainage and everything, the extra holes put where one wouldn't ever think about it, definitely caused a lot more.
Yeah, like exactly.
Yeah. And Sandra says, you gave me hope. Thank you. Oh, you're welcome, Sandra. You are welcome. You had some great advice and from Meghan. So anything else? Any other comments from anyone? Any other questions? I'm not seeing any more.
These are the things, like, whenever we work with people, we know, particularly, anyone who has a pelvic floor dysfunction, what we're trying to do as a medical community is to get providers to be more proactive in asking, because we know if we don't ask, patients don't tell. And there's so much that we can offer, and not just from a self-promotion perspective, but there's so many different things and therapies out there that can be utilized to help these different conditions. And they're really more worldwide available than they ever have been in the past. And so, especially with my relationship with Harvard Medical School and teaching the new breed of physicians out there, what the pelvic floor is, how does it impact all of our patients, because all of us have a pelvic floor, and what are the different therapies out there that can be used to help, but more importantly, physicians and clinicians have to be asking patients these questions, asking about their sexual function, asking about their bladders and their bowels. So patients are much more inclined to like tell us more, and not just to have them be ashamed and feel like they're the only person out there in the world with this, but there's lots of people out there that do have these issues. And thankfully, there are a lot of providers out there that are more than willing to help. And we have really great evidence from good, rigorous, controlled trials that speak to the efficacy of the things that we do to really give patients their quality of life back.
That's such a perfect wrap up of it, just to know that you're not alone, because so many people are afraid to talk about this because, everyone thinks, that they're the only person.
Oh,
So there is help out there, and just being informed and knowing that you can find someone to help you. So thank you, Meghan. I think we'll wrap it up on that note. You have provided so much insight and amazing information, and I thank you. I've learned a bunch. And if anyone is watching this on the replay and you have questions, post them up there, and I'll see if I can get any answers for you from Meghan. So thank you, Meghan. So thank you, everyone, for joining in tonight and for participating. My name, as I said, is Elaine O'Rourke. Please go to my website if you are struggling in any way. I help people with the mental, emotional issues of having an ostomy, of having Crohn's, having colitis, and really help people get back on their feet again. So my website is elaineo'rourke.com. You can grab your free guide, 3 ways to eliminate fears about your ostomy, or your free guide for Crohn's and colitis, about 5 mistakes even well-informed people make with IBD. Please follow me on YouTube. You can subscribe there as well. That is really helpful. And my new Instagram page is Ostomy IBD Life, and it's the same name on Facebook. Next week is for male sexual issues. I'm delighted to have Dr. Neil Nandi on, and he's another GI specialist, and he's going to be talking about that. So males, get on and tune in next week. It's live at 5 USA time, East Coast. And I am here in lovely Ireland, where I'll be for the next little while. So tune in next week, and then we'll take a break for a while, and I'll hopefully be back again in the new year. All right, everyone, stay well, and I will look forward to seeing you again next week.